I'm Andrew Wallace, and it's my pleasure as Chairman of the Research and Education Committee of Fortius Clinic to welcome you all from around the world to the Fortius International Sports Injury Conference 2017. Our name Fortius derives originally from the Olympic motto, Citius, Altius, Fortius, faster, higher, stronger. And in some respects, this reflects our aspirations for what this conference will achieve over the next couple of days. This is our second meeting since 2015, and already this year has been an exciting year in sport, particularly here in the UK. We've seen the World Athletics Championships have been held here. There's been a Lions tour to New Zealand, a Six Nations victory for England, and even as we speak, the Invictus Game is being held in Toronto. It's also been a year of individual achievements in sport. For example, Chris Froome winning the Tour de France and the Vuelta a España, and also Mark Bowman cycling around the world in under 80 days. Not quite sure why anyone would want to do that, but it's an achievement. Also, we've seen Jimmy Anderson take his 500th Test wicket, an amazing achievement for those of us who've got to know him professionally. And I think there's an Ashes tour in the pipeline coming up, and we'll see how that goes. Equally impressive has been the rampant success of British women in sport, in hockey, football, rugby, and in cricket. But there have also been challenges, and for example, witness Andy Murray's struggles with his hip injury, and only an article in yesterday's Times that looked back over 15 rugby players who were tipped to be the up-and-coming stars of tomorrow, who've all had their careers cut short and been crippled by injury. And these demonstrate the high attrition rate in elite sport. This year's theme is from start to finish, and this will underline the whole program over the next couple of days, ranging from the identification and treatment of injury through to rehabilitation and return to sport. In many respects, our efforts as clinicians are just as much a team effort as those players that we care for. In team sport, every player must respect and value the worth of every other player to get the job done. And in the same way, sports medicine can deliver the best outcomes when we work as a team. Over the next 2 days, we'll be sharing thinking and strategies across many disparate disciplines in order to gain an understanding of what constitutes best practice in 2017. In developing the content, we have focused deliberately on a multidisciplinary approach, focusing on hot topics and controversial issues, such as hip and groin pain, concussion, tendinopathies, and return to sport after spine surgery and even after joint replacement. This year we have placed a particular emphasis on imaging, such a critical part of modern diagnosis, and also on more contributions from the allied health professions. So I encourage you all, whether surgeons, physicians, radiologists, physiotherapists, osteopaths, chiropractors, sports scientists, or representatives from industry, to catch up with old friends and make new friends. I would also encourage you to venture into sessions that maybe are outside of your core area of interest, because you never know what you might learn and find. We have brought together a large and distinguished faculty from all corners of the globe, chosen for their expertise, passion, and their communication skills. And just as we are looking forward to hearing them speak, we are also looking for rigor in the timing of the sessions, because an integral part of this conference is the contribution that you as delegates will make to discuss, engage with, and even dispute the material that's being put in front of you. In every session, there is a good amount of time allocated for questions from the floor. You'll find comprehensive information in the brochure, but also on the conference app, which you can download through the link. If you have any problems, please contact one of the Fortius staff, and we can help you to do that. It will allow you to plan the day, rate the presentations, and importantly, that's the way you're going to get your CPD certificate at the end. This conference and all of us at Fortius are dedicated to the pursuit of excellence in sports medicine, but it would not be possible to hold this not-for-profit event without the generous support of our sponsors. The relationship between the practice of sports medicine and the clever companies who make the kit that we need to do our work is vital. And I've made many good friends in the industry who I recognise share the same values as we do. And I would urge you to spend some time going around the exhibits and stands and talk to the representatives and engage with them. Having said all of that now, it's my great pleasure to introduce this morning's session, and In particular, it will be chaired by Jonathan Houghton. Jonathan is doubly qualified in sports medicine and rheumatology and has experience in military rehabilitation from working at Headley Court. He is also the Chief Medical Officer for Surrey Cricket and for the Welsh Football Association. He has special interests in the role of diagnostic and therapeutic ultrasound and also in the vexed field of tendinopathy. I'm now very happy to leave you in his capable hands for the rest of the session. Good morning.
I'm going to talk about the conflicting demands on the clinician when treating elite sports people. Now, many of you in the audience will already be working within this field. This is a personal view, backed up by some literature, but hopefully it will be of interest to you all. What is conflict? And if we go to the Latin, it's a contest, so it gives us the sporting sphere. So I think that certainly you can see the dictionary definition of conflict will bring up some definitely some triggers of when you're working in elite sport. So a clash of opposing feelings, very, very common. Secondarily, I think this is very common for all medical rooms, a serious incompatibility between two or more opinions. I'm sure you've seen that many a time. And certainly, from a personal perspective, feeling confused and mutually inconsistent feelings. And I definitely feel that a lot of the time. But elite sport is different to a lot of areas of medicine. And this is the nubbins of it, really. Essentially, you need to work about 180 years to get one injury if you're working in a desk job. So very few of us will get injured at work, and the health and safety executive is very pleased about that. And even such trades such as mining that have a very high attritional rate, they're very well regulated. Now, I'm still surprised that football's going on because the health and safety executive clearly states that it's a highly dangerous sport. You're 2,000 times more likely to be injured at work as a professional footballer and about 500 times the risk of mining. And also, we know about 50% of footballers will retire through injury, either acute injury or chronic injury. So this is a profession where people are risking serious health risks. You know, significant major injuries are possible. And what's different is that many of your consultations might be you and one other person in a clinic room or on a ward round or in your practice. In elite sport, rarely do you get to sit down with one person, have a discussion about their problems, look at their images, and then come up with a plan. There are multiple stakeholders in elite sport, and this is just a few of them that I've listed, and I'm going to go through some of those conflicting demands. So from the athlete themselves, and I think it's important to remember that you've got multiple conflicting opinions, but also so will the athlete. The athlete's not an island. They will have multiple people talking in their ear about what should be going on. The coach is going to have a very different perspective to you and to the player. The owner is going to be involved. Your own medical team colleagues will provide a source of conflict. The teammates of the athlete who's injured, other medical professionals that take second, third, fourth, fifth opinions, your family, the patient's family, the media, governing bodies, the list goes on, and hopefully I'll be able to show you some of those. So the primary person is the athlete, and on the whole, if you ask athletes, you know, what does your medical team do for you, then they're primarily thinking that you are there in terms of diagnosing injury and protecting them, making sure that they're not coming back too early and risking ill health from premature return. Often, as a medical professional, you might be just dealing with their general health, and more these days, medical and science people are involved in getting the best performance out of their athletes. But what are the sort of influences that the athletes have from a psychological perspective when they're injured? And I think we all just presume that athletes are just desperate to get back on the field. And the vast majority that you've dealt with will be that way. They've got an overriding desire to compete. That's an inherent competitive edge within them. But there's also a lot of other psychological issues that are going on with them that want them to get back on the field. When they're injured, there are certain things with self-betrayal of their body image, they get alienated from other players within the team, and certain other negative feelings that want them to be doing their thing very, very quickly. But it's important to remember that the flip side can be true. And when you're dealing with elite athletes, you've got to pick up the times when they don't want to come back quickly and explore the reasons why that may be. And certainly, fear of re-injury, certainly following a major injury, is a massive one. They're worried about their performance if they're not 100% fit because there's massive expectations on them. They may have a lack of confidence or be worried about their long-term health. And what are some of the sociological influences on athletes in terms of return to play? And this is really why most athletes are prepared to risk a much higher rate of occupational injury, because their status amongst their peers, amongst society in general, is much higher than those who are non-athletes. They're also working to pay their mortgages and look after their family, and financial remuneration is a key issue to their influence to get back to play. So really, everything focuses around risk. And when people say to me, what's different about working with elite sport compared to Joe Public in your clinic? And for me, working in elite sport is all about managing risk. And risk is essentially the probability of something happening, i.e. how likely it is, times the consequence of that particular event. Now, if I see a 40-year-old jogger who does a couple of 5Ks a week with an Achilles tendonitis or tendinopathy, then if I'm thinking about doing a high volume injection or something like that to take away their pain, I'm thinking, well, okay, what's the probability they're going to do something bad after this if I talk to them and they're sensible? And then what happens if they do get a tear after I've done the injection? That's very different risk to a professional footballer mid-season who you know is going to load that tendon as soon as you have got them out of the door, despite what you say, plus the fact that they've got 4 games coming up in the next 10 days. So return to play decisions are all about managing risk, and there are multiple factors that will influence that. And if we overcall the risk, then we're going to stop people participating in their sport unnecessarily. But on the flip side of that, if we undercall the risk, then there's a risk of serious injury for that particular player. So Ian Schreier did a very good publication where he's done a couple of publications now, and thanks to him for some of his slides. He came up with a sociological and psychological framework for thinking about return to play decisions. And I'm just going to go through that in a bit more detail. So within that framework, he has 3 stages. The first is assessing the actual state of health and looking at tissue health. And there's not a huge amount of conflict here. You know, we know how old the patient is, they say what their symptoms are, they repeat that to the same people. You can elucidate physical signs, and there might be an MRI scan showing this. So there's not a huge amount of conflict in that section. When you're then looking at what do they have to do, again, not a huge amount of conflict here. What position do they play? What are the demands of the sport? You know, what level are they playing? Step 3, this is where we talk about risk modifiers. So what are some of the influences, once we've looked at the tissue health and what they've got to undergo, what are the factors that then influence our decision about whether they're ready to play? And this is where pressure from the athlete comes on, what the coach and the manager wants, what level of analgesia you might use to mask a particular injury, what are the professional and sort of legal implications of them playing, what stage of the season are we at, you know, is it an important game? And I think I just wanted to show you a tiny case vignette. This is one of the Welsh internationals, and in our final warm-up game in the pre-Euro camp in Portugal, he went down as though he'd been kicked in the back of the leg. We all feared the worst, thought he'd ruptured his Achilles, but actually he'd ruptured his plantaris. So not quite so severe an injury, but still a pretty big one. And this was 1 week before we were about to fly to France. So plantaris injury, and you know, over that period of time, there are a significant number of interventions, but the risk modifiers for that particular individual at that point in time were very different to this being a cold injury or a non-professional player. So we had a professional athlete who was out of contract with his championship club. So he was looking to perform well in the Euros and get his next move. We're a week away from the biggest tournament that Wales has always ever qualified for, and there's a huge amount of pressure to get our best players. He was one of our starting 11 players on the pitch. Now, he did actually make the Euros, and there were certain decisions where there was a significant amount of risk in whether he was going to be fit to play or not. This is the sort of numbers that we're dealing with, and we get very het up by Premiership footballers and how much they earn. So if you play for Burnley, you're going to earn just over £1 million a year. If you're Manchester United, more like £5 million. And we think that's far too much, but it's small fry, really. If we look at the American model, across the NBA, the average salary is $6.2 million. That's average per NBA player, and they've got huge squads. So the figures involved here are absolutely enormous for the players. And interestingly, we know from evidence that this influences our own personal decision making. So again, this is some work by Shreya, where they asked a number of medical professionals, they gave them a scenario of an American football player who had an AC joint injury. And the examples along the bottom there, example 1, 2 to 6, was increasing signs and severity of that particular injury. And they asked them, are they fit to play? Now, if you say that player's a goal kicker, then many more people said, yeah, of course he's fit to play. If you say he's a linebacker at the line of scrimmage, then a lot less said that. But if you said he's got a chance of $1 million sign-on bonus if he plays this game, then pretty much at every level, the health professional was twice as likely to say, yes, he's fit to play. So there's no other changes in that scenario. So it does influences. What about the coaches and the managers? What are they after? And this is the bottom line, is injury leads to failure in professional sport. And it sounds obvious, but this is probably one of the only publications that shows that in great detail. And the UEFA Champions League 11-year follow-up. So they looked at over 1 million exposure hours, 8,000 injuries. And you can see that there's quite a high rate of injury at over 26 per 1,000 hours. And it's not rocket science, but injury and availability predict results. So in the UEFA Champions League over 10 seasons, if your injury burden is low and your players are available, you're much more likely to come higher in your league and have more points. And that's what the coaches know. And the owners know this also. For every month that their superstars are out, it's going to cost them close to $500,000. These figures are a few years old. And that's a number of factors that influence that. What are the influences on the manager? And this is just some data from the English Football League. So there's 92 clubs in the English Football League. Last season, 56 managers were sacked and 16 of them resigned. So 72 out of the 92 clubs had a managerial change. Well, actually, some were probably 3 managers per season. But that's a huge attrition rate, all down to performance and results. That's the sort of level that the managers are dealing with and the pressure they're under to get results. What about the agents? Well, they're certainly got an eye on what's important for their player and whether their player is playing. So this is Neymar and his dad, who's his agent. He had a nice 10 million signing on agreement with Barcelona, 40 million euros when it went through. Last year, contract extension, the agent took 27 million. And then when he moved to PSG, he had a loyalty bonus, which kicked in on the 1st of August of this year. And then on the 2nd of August, Neymar signed for PSG. And now Barcelona are trying to get that money back. What about your colleagues? There's definitely conflict with your colleagues. And this is looking at the Canadian Sports Medicine Association. And it's a bit of a busy slide, but essentially what they did was they went to the Sports Physicians Association, the physical trainers, the physiotherapists and the chiropractors that all worked within sport. And they said, who is the best placed person to rate the risk of re-injury, look at short-term problems and look at long-term problems? And surprise, surprise, the physios said it's physios, the chiropractors said it's chiropractors, the doctors said it's doctors. So even amongst ourselves, we think that we're the best people to do it, and don't think our colleagues are the best person to do it. What about the influences of the media? And I think, I'm not sure if James is still doing his live surgery. That would terrify me, doing surgery in front of everybody. But actually, when you're working in professional sport now, you know that the media is going to scrutinise what you're doing. You know, they know your name. Doctors and physios are in the paper now. You know that when you're doing your job, there might be 150 million people watching, depending on the importance of that game. So everything you do is going to be scrutinised and recorded forever. Now, is that going to change how we do our job? Are we going to become more defensive because of that? I think maybe so. And just to say, you know, again, there's the camera view from the spider of that particular incident, and that was just being streamed live throughout the Euros. What about confidentiality within the media? On the first morning of our first game, everybody's excited. Wayne Hennessy, our keeper, wakes up with a locked facet joint in his back. He's had problems with this before. He's struggling. He can hardly walk. Myself, Shaun and Rodri, we're sitting in the hotel thinking, how are we going to get through this? Can he play? What are our options? Having a discussion. And then suddenly we find out that TalkSport's just announced that he's not fit. This was within an hour and a half of me finding out about this that morning. Confidentiality is very difficult. You work in an open medical room. Often I'm in a hotel room with 4 couches next to each other. You can have a medical consultation that's about 2 yards from the next player. Most players know exactly what's going on with all their teammates. Injuries happen on the field of play in front of the cameras. The media will report on them. They're hugely interested in it. Decisions on fitness affect selection, and if a player is being transferred, then the owner of one particular club will want to know absolutely everything about that player's medical history before they sign. So we're talking about an area where confidentiality can sometimes not exist. It's worth reading the faculty's professional code, and that gives a bit more advice on confidentiality. And this is a nice PhD paper from Malcolm last year. It's well worth 5 minutes of reading. But essentially it says that ethical principles are very much related to that particular social situation. And you've got to understand a complex environment that you're working in. And it's saying that effectively the research will show that there's a massive variability in how particular practitioners in sports deal with confidentiality. So amongst us, we're not very good at towing the line about what confidentiality means. What he recommended really was that we should be very clear about what our roles are, whether there should be full disclosure, maybe for an occupational role. If you're a primary care physician, maybe that should be completely confidential. But essentially everybody should understand what the boundaries of confidentiality are, and he argues against having sort of strict contracts between medical professionals and professional clubs because it will bring about more conflict with particular cases. It's easier to have a sort of non-contractual obligation so that you can take each case by case. What about the lawyers? And we've got Majid coming and talking soon, but legal issues are becoming more prevalent, certainly in concussion, the $1 billion lawsuit in America, and the Zurich concussion statement on the right. I'm just being devil's advocate here, but this is a huge amount of money, and so far there's been absolutely no scientific evidence of the connection between CTE and concussion. I suspect there will be, but if we're practicing evidence-based medicine, there isn't at the moment. And much of the concussion guidelines that we follow at the moment are pretty much just drawn out of the hat. There's no scientific evidence for them. Having said that, it's clearly an important issue, and I'm sure the concussion session will be interesting. Families will exert a huge amount of conflicting demands on the athlete, not just the athletes, but your family. Working in professional sport, there are consequences and there are sacrifices that you have to make. There's lots of travelling, there's lots of time involved, there's lots of time when you're with your family and you'll be called for advice, for example. Doping is clearly important, and just this week, the Turkish athlete who won the 1500 at the 2012 Olympics, out of the first 9 athletes that finished that day in London, 6 of those 9 have been subsequently banned. The athlete who won that has been banned for the 3rd time. She got an 8-year ban in 2013 for a second doping offence, which was halved, and now she's been found guilty again. With all these people that are doping, there are doctors that help them, and I think that there are clearly conflicting demands. And lastly, talking about yourself, and nobody ever really talks about this. When I was at medical school, that was what I thought a rheumatologist was on the left. A little bit geeky, not really the person you want to hang out with. Sports medicine, however, sports medicine's sexy. It's up there. It's where you want to be. Fortunately, I'm dual trained, so you get a bit of both. Personal conflict's hugely important. When you see someone, you want them to choose your opinion. They might have had 5 opinions, and when they don't take yours, it hurts a little bit, and you have to get used to that, and you have to live with that. Also, I think most of us in the audience who work within sport are like sports people. You want to win, you want to compete. How is that going to influence your decisions about whether a player is fit or not? If you're at a major competition, you want to win. You want to keep your job. You want to earn the money. So these are all things that will affect you working in professional sport, and we never really accept that that's an individual responsibility. And also, you've got to know your own ego. You know, working at elite level is fantastic, and it will tickle you, but you need to understand how you're going to deal with that and how it influences your decision making. So in summary, I think working in elite sport, multiple conflicting and very sometimes impossible demands. Remember though that the athlete in front of you is also under multiple demands and huge influence. So people always talk about knowing your sport and knowing your player, but I think it's really important to know yourself as well. So hopefully that will be the take-home message for you. It is incredibly rewarding though, and it will provide you with some memories that you just can't buy. So thanks very much for listening.
I know this is obviously a medical conference, but I thought it'd be quite nice to kind of lead off from what John just mentioned about coming into the setup, how you, as a manager, follow such big footsteps and kind of transition into your style of managing and how you went about doing that.
I think the Welsh team, obviously everybody sees the finished article, which is the team on the pitch. And we've got some great players, obviously Gareth Bale being one of them. Not very much is the finished article, but to get to that stage, there's a hell of a lot of work has to go into it. So 6 years ago, the dog touched on it earlier. Normally, in my industry, if you get a job, if you're replacing somebody, it's because they've either had a bad run of games and they've had the sack, or they've had a good run of games and then bigger opportunities come along and they've moved on. You never get a new job because someone's lost their life. Harder for us, all of us, because we knew Gary so well and he was such a top fella. Someone I knew, he's my friend since we were 10 years of age, so the circumstances were completely different, new territory, and you know, for the first 12 or 18 months it was incredibly difficult, as you see the results. So it was quite tough on every level at the start, taking the new job, but I felt that we needed a new culture in Welsh football. I think I immediately looked at other countries in terms of the players they had and how many caps they got for their countries, you know. Yeah. I looked at Croatia, Bulgaria, Romania, countries like that, and had players of gaining over 100 caps, and we've never had anybody in our history.
Yeah.
So, you know, we literally laid the law down to the players and said, who's going to be the first one? You know, something has to change here in our psyche, in our mentality. Clearly, we're not taking it seriously enough. Players playing for Wales. Why does it appears it means more to other countries, to their players, to play for their national team than it does to us? Because none of us have ever got 100 caps. Yeah. Now I'm pleased to say 6 years on, a lot of our players, 50, 60, 70 caps. Chris Gunter's 27 or 28, 60 consecutive caps, and he's played 84 times for his country, which is an incredible record. So that was the, you know, we offered them a challenge, if you like. Yeah. Not to miss games, take it more seriously. And to do that, most of our players play for Premier League clubs and Championship clubs. They come out of really top-class professional environments. That means we have to then, in our structure, we have to have good training grounds, stay at good hotels, travel properly. The players have to eat properly, rest properly. We have to be as top professional in our mentality as we possibly could be, as our financial structure would allow us. Yeah, sure. And I'm pleased to say that our association backed us on that, invested. We tried to take all the excuses away from the players, because the doc said earlier, we hadn't really done anything for 60 years as a country. We've come close, and we'd always settle for second, or, you know, oh, that was unlucky. Yeah. Never really did anything. So, you know, it was a big challenge that we laid down to the players, but we needed to change the infrastructure. We needed to change our mentality on and off the pitch, become more professional. And then when you do that, it was a big change. You sink or swim. Either the players are going to take that on board and enjoy the challenge, or they're going to shy away from it, not follow you. And if that happens, then, well, I wouldn't be sitting here if that happened.
And I suppose, I know you're in a medical conference right now, so you'll probably answer with a bit of a bias, but how much of an influence do the medical team have on that transition? And I suppose also how much of the challenges are between linking in with, say, the Premiership, Championship, getting that information across so that you can prepare your camps to be as effective as possible?
Well, I think the reason why it's been some time now since I've had concerns about, in my first campaign, which is 5 or 6 years ago, some games I'd name a squad of 23 players, and sometimes 14 or 15 players would pull out of that squad. Okay. So you really are going into a challenge with your hands tied behind your back. And we've had to build up trust with clubs. That's not necessarily me speaking to a manager of a certain club about a certain player. The trust has been built up from medical team to medical team. It means that my job, predominantly when I'm speaking with a doc, our physio, Shaun Connolly's here, our head physio, any of our medical team. And the questions I ask, can they or can't they? Can the players play or can't they play? How long can they play for? And it's basically, from my point of view, is trusting our medical team, which I do 100%, and then not going back on that, not breaking a promise to the club.
Yeah.
If we say we're playing the player for 45 minutes, that's how long he plays for. Yeah. We never take a risk with the player, and we try to send the players back to their clubs at least in the same condition as we received them. Now, it's got so good with us because of the medical team. Our players sometimes turn up when they're injured because they get good treatment with us and they get looked after. And we have that trust with the clubs. And like I say, it's not because of my personal relationship with a manager. It's more medical team to medical team. Everything we do is documented. Yeah. Clubs can have any information on our players, from what they've eaten, how they've trained, the length of the training session, the loading, physical side of it, to how they've been treated. Everything's documented, so they've got complete understanding of what we've been doing with their players. And I think, but we get that trust from medical team, the international Welsh medical team, to the Real Madrid medical team. There's transparency, and that's how you build trust up.
And I think you touched on it a little bit just before, but as a, the manager, how much information do you want about the injuries? Is it as simple as, are they fit, are they not on times, or do you want to know a bit more detail?
No, I think because we've been together for some time now, so we all know I trust. I've been involved in professional football for a long, long time as a player, as a coach for a while, and then maybe 15 years as a manager, and I've never understood why people like me, managers or coaches, think that we know more than the physio or we know more than the doctor. How come we? That can't be. And the reality is we don't. Our ego may tell us we do because we're a boss and we have to have the final say. But I've always looked at that as an insecurity from people in my industry. I think you've got to look at people who you work with in different departments. You get the best people you can get your hands on that are good at their jobs. You trust them, and then you go with what is reality, And I think for me, I asked the doc, or I asked Shaun, our physio, like I said earlier, what's the possibilities? Yeah. And they'll say, you can try. There's a 50% chance he'll break down. He could go in the red zone in the first 20 or 30 minutes. He could have a reoccurrence of an injury. And we're all under the understanding that we never take that risk, ever. It's not worth it in the long run. Yeah. Because you end up, if you do that too many times and you lose players and you send them back to their clubs injured, eventually those players or the managers of that club will put an obstacle in your way down the line if you get that player back. So if the doc says to me he can't, I'll say, what's the problem? He'll tell me it's this, and this, and I'll say, fine, park that up, let's move on. But you build that trust up. And luckily for me, the medical team I have around me, they've never let me down, and there's complete trust there. So I don't say I'm going to override that, or I'm the manager, my decision's this. That's pointless, and it's short-term thinking.
I mean, it's certainly probably music to a lot of our ears here, because certainly I know I've been pitch side, radioing up saying we agreed 20 and we're already at 30. So it's great, clearly been successful from that side of things. Have you seen the medical team and the support evolve since you were a player, and do you think that might have changed your career pathway? I think,
football itself it has changed. There's no point in saying it hasn't. I think I hear a lot of new terminology from the coaching, from managers who maybe think they've reinvented football on the pitch. Off the pitch, it's changed for the better, I think, certainly medically. When I played, it was, it wasn't a 23-man squad, it was a 13-man squad, 2 substitutes. I can't remember, Dean Ashton's here, and he'll be speaking with us later also. I can't remember, I'm doing Dean a disservice, I was probably before his era. I can't remember playing a game when I was 100% fit.
Yeah.
When I got to 2021, things started happening. I made my debut when I was 17. I played, I think, 150 games by the time I was 20 or whatever. So I was game hardened. And then you pick up knocks and bumps and bruises. I can't remember being 100% fit. You just get used to that. But the game's moved on now. It's faster. There's probably less big impacts like there was 20, 25 years ago. But the players are faster nowadays. Everything's moved on. And I think we look at modern day players maybe, and we're probably judgmental of them that they don't play unless they're 100% or quite a lot of them. But it's different. I think society is different to 25 years ago. So medically, though, it's definitely better.
Yeah.
It's safer.
Yeah.
It's a better environment for a professional footballer to be around. And I think it needed to get better. But the problem is with football, we're very arrogant, but we're behind in what we were on lots of levels. Because football's the biggest sport in the world. We think we've got all the answers. You know, financially, it's on an incredible level. But that creates an arrogance in football. But I'm glad to say, certainly in the last 10 to 15 years, I've seen it slowly turning for the better, certainly medically.
Yeah.
But it definitely needed to.
Yeah. I mean, one of the questions, although I'm not going to ask you to answer it, was do you think the players are softer nowadays? But you don't need to ask that one.
Not the Welsh players, no.
No. So John also mentioned, obviously, the psychology of returning to play. Do you have psychology or kind of any support within the team?
I mean, speaking from experience, when I was a player, and football was everything to me. You know, I couldn't think past a Saturday afternoon. Training Monday to Friday, I enjoyed the training, but it was about the game. It was about Saturday afternoon, being in the dressing room, being a part of the team, the smell of the dressing room. You could hear the crowd waiting and all that excitement. It was all about that. That's all I lived for. But I think, you know, if you get a nasty injury, it's not just the physical side. It's not. It's probably more the mental side.
Yeah.
It is. And psychologically, you have to be of a certain way in your thinking. You have to stay positive as much as you can, and that's not easy if you love playing, if you love that 90 minutes, and you know at the end of the week of your work with a medical team, you're not going to get that 90 minutes.
Yeah.
The longer that goes on, it has an effect. And it's quite tough to deal with mentally.
Yeah.
Psychologically, it's very, very tough. When we have a psychologist in our Welsh setup, Ian Mitchell, who's played football actually as a semi-pro, and he's fantastic. Because I think, again, like I said earlier, we are, I think, a little bit in our thinking in football, a bit arrogant. Lots of different sports have psychologists.
Yeah.
It's kind of frowned upon in football for whatever reason, which I don't agree with. But we've got one with us because I know psychologically you have to get that right. Players coming back from injury, players dealing with injuries. It's not just the physical side of it, it's the psychological side also.
Sure. And probably it'd be quite nice to finish off on kind of maybe looking at what you see is different between the British football versus European, and because obviously you've got a lot of experience in that as well. So medically, are they similar or are they very different?
I think, if we're honest, I think a lot of, you know, I've worked abroad, and a lot of countries, you know, certain countries where we've looked at, maybe 20 years ago, when we look, oh my God, look how fit those players are. How can they sustain that level of performance? Only to find out 15 or 20 years later, a lot of what those players, football clubs, big football clubs abroad were doing was illegal with their players. So I think there's another way to look at it also. Definitely in terms of, the thing is, when I worked in Spain, the standard of football is different. Technically it's very good. Physically it's not the same as the English Premier League or the Championship. It is brutal, the English Premier League and the Championship. It's brutal, it's tough. It's long seasons, every game's a fight first.
Yeah.
I worked in Spain, it's slightly different to that. It's more technical.
Yeah.
So the physicality is much different, and I was asked about our player, Gareth Bale, who plays for Real Madrid. Would I like to see him coming back to Manchester United? And from our perspective, from being selfish, not really, I wouldn't, because he's less likely to get injured playing for Real Madrid in the Liga as he is for playing Manchester United in the Premier League, because you can play for Man United, Man City. You know one thing, you could be playing against Crystal Palace, who are at the bottom of the league. Crystal Palace could be 2-0 down with 20 minutes to go. They won't give up. They'll still be going hard at it. In Spain, it's different. The football is different. He's playing for Real Madrid. If they're 2-0 up with half an hour to go, the game's finished, generally.
Okay.
Tempo's lower, tempo's slower. So I think from us, there's less physical output for Gareth Bale playing for Real Madrid than it would be playing in the English Premier League. That means we get him 9 times out of 10, and we get him in better condition physically.
And do you think he's hardened and ready for the international setting, even though he might have had a bit of a softer journey leading into it?
No, yeah, because I think physically he comes with, well, mentally, psychologically, he's in a great place when he plays for Wales, fantastic. Physically, he's still got lots in his tank because he hasn't been 90 minutes, three times a week sometimes, where physically it's very tough also. It's more technical in that league. So we get him physically, he's in a good place.
Fine. Quite a few people wanted you to answer this question, but I'm worried about what the answer might be. But do you sometimes get players telling you different things than they would tell the medical team?
It's actually reversed.
Okay.
They'll probably speak with the doc or the phys or the masseurs more than they'll speak to me. If they want me to find out something, they'll say something to the doc or to the physio, and that'll get back to me if they wanted to get back to me. But players very rarely, I mean, that's another reason why I like the sports psychologist. They'll tell him more than they'll tell me. I find out what I need to find out. If the doc thinks I need to know something, I'll know that. He'll tell me that. And if he doesn't think I need to know that, or Shaun, then they'll know I don't need to tell the boss that. He doesn't need to know that. So I don't pry. I think, again, that comes down to that word, which is a big word, is trust, really. And if you've got that, then, you know, I think it saves you having sleepless nights.
Brilliant. Well, thank you so much for obviously opening up the session.
Thank you.
I'd like to introduce Majid Hassan, who's a partner at Capsticks. He's one of the leading lawyers in clinical law and litigation, and has worked with a number of high-profile cases in the NHS and in sports. He's got a specific interest in emergency medicine, orthopaedics, and also sports medicine, and has been doing a lot of work in sports governance. And I think what he's got to say, I think, might be fascinating and quite scary at the same time. So, Majid, all yours.
Thank you very much, and thank you for inviting me. Hopefully not too scary. No one's going to lose too much sleep over this. We're going to talk about elite sports care, but actually, before we go to the elite level, I want to just start off with injury case that came out of the Leamington League in a game between Whittle Wanderers and Kelso. It was a case that went to the Court of Appeal just down the road. And this was a case where the plaintiff, Mr. Condon, had suffered a fractured leg in a bad tackle, and he sued the other player. And what was quite interesting about this case, it was heard in 1985, and the court said at that time that this was the first time a case had come before the court where they were being asked to consider the issue of duty of care in the context of professional sport, or even amateur sport for that matter. There was very, very little case law around it. In the 30 years or so that have passed, sport's become increasingly commercialised. The financial benefits for both clubs and sports professionals have significantly increased, and that in turn has meant that when things go wrong or badly wrong, the financial compensation that's involved is significantly greater, as we see. So this session is really about looking at the sort of basis for some of those claims, why they happen, where are the areas of risk, and what can all of us do, whether you practice in the elite level or at an amateur level, whether you're a doctor, a physiotherapist, or a sports scientist, what can be done to minimise your practice. So This is what I call the Have I Got News For You round, the 4 pictures. I'm not going to ask anyone to name what they all have in common. Starting at the top left. So these are all cases that have ended up in the courts over recent years. Michael Appleton on the top left. Michael Appleton was advised by a knee surgeon to undergo surgery for cruciate ligament. It was felt that he was advised inappropriately, and a claim was brought by him against his surgeon for in excess of £5 million, I think it was, and he recovered in excess of £1 million for that claim. What was quite interesting is that his club, West Bromwich Albion, then also brought a claim against the surgeon involved on the basis of a contract between the club and the surgeon for provision of appropriate treatment. That claim was thrown out by the court. It was dismissed outright on the basis that if that was upheld, no surgeon in England would be able to treat a player on referral. Next to him is Radwan Hamid. Radwan sadly suffered brain injury. He had a cardiac condition which was reviewed in accordance with the FA programme. The cardiologist reported to his club, Tottenham Hotspur, but somehow he was lost in the system. The appropriate follow-up wasn't done. He collapsed on the side of the pitch during a academy game and suffered brain damage. He recovered close to £7 million a couple of years ago. Underneath is Kieran Brady. Kieran played at Sunderland, and he brought a claim, I think it was in 1996, for around £2 million at the time, on the basis that his club, the manager and the physiotherapist, as well as 2 doctors that he had seen, had both failed to pick up his very, very rare vascular condition. He had popliteal artery entrapment syndrome, which some may see only once in their career, if that. He brought a claim, as I say, against the club as well as the treating physicians, but that claim was dismissed because his evidence wasn't accepted, that he'd warned people, he'd given explanations as to what was happening, and that was ignored. So his claim failed. But just to show it isn't just football, on the bottom there is also Killian Willis. This is an important case because this is the first reported case of a player bringing a claim in professional rugby against his club. He's arguing that his club failed to properly manage his concussion, and that caused an end to his career. So these are clearly significant cases in their own right, the impact upon the individuals concerned. Of course, the other impact of this is that it's brought to the fore the issue of sports litigation. These are just some of the cases. I can name you a whole range of other cases that have come about. What it's also meant is that the defence organisations who've traditionally covered doctors for their private practice have decided to withdraw from the market, or certainly made it much more difficult. And now there are other policies on the market because many of them have looked at it and thought, if these cases do get to court, if they do succeed, the amount of damages involved could be very, very significant. So why are the damages significant? Before I just get to that, Jonathan did an excellent presentation earlier on the dynamics of the relationship, and that's quite important, I think. Very different to the traditional doctor-patient relationship. There's many more factors involved. For litigation, there may be issues over language, there may be issues over perception of the Health and Safety at Work Act by club owners who may be foreign owners, etc., not really appreciate it. So the environment is very different. But there is claims inflation. Claims are increasing faster than house prices as earnings increase in professional sport. The value of those cases goes up, as I've just indicated. The value of cases generally, particularly in the field of clinical negligence, has significantly gone up. You will have seen in the news the results of the National Audit Office report, which estimated that the 1.6 billion that was paid by the NHS last year in claims could probably double by 2021. Because the value of claims is going up. Is there a litigation culture? Well, there may be. Certainly the no-win, no-fee claims that we've seen, the mode of funding has probably contributed to that to some degree. But people are entitled to compensation if they suffer injury. But there is a greater amount of litigation, and there's a greater awareness of medical problems. The one area I want to focus on is also the issue of informed consent. Many of you will have heard of the case of Montgomery. Any doctors I go and talk to say, gosh, you're going to talk about Montgomery again. I just want to very briefly mention this. This involved Nadine Montgomery, who was awarded damages after her son was born with severe brain injury. She had all the markers for a high-risk pregnancy, and certain risks could have materialised. She was small, she was diabetic, her fetus was very large, and she wasn't warned of the risk of shoulder dystocia, which was put at 9 to 10%. Her doctors accepted that she wasn't warned, and they said, well, we wouldn't warn, because if we did warn, then every woman in that situation would want a caesarean section, and we don't have the money to do that. We don't think that's in the best interests of the mother. And the court decided, no, she should have been warned. It's not for the doctors to decide what a patient should be told. They should be told all the options, and they have to be warned of material risks. She did suffer that risk. Her baby's, the emergency that occurred was shoulder dystocia. The posterior shoulder was caught during their birth process, and that's her baby suffered injury. So the court's now put in a test in regard to material risk, a much more subjective analysis. That's the definition of material, whether a reasonable person in the patient's position would consider this to be a risk that they should be warned about. So it's a much more subjective approach and an informed consent approach. So gone are the days in the past, the fictional character of Sir Lancelot Spratt saying to a patient in the film Doctor in the House, "Be quiet, my good man, this doesn't concern you, you don't need to worry about this." Gone are those days, thankfully, that was a long, long time ago, but it is much more about informed consent, a subjective analysis, telling patients what they need to know. The principle also applies not only to treatment and advice prior to undergoing surgery, but also post-operative advice. In the Spencer case, there was a failure to warn of the risk of pulmonary embolism and DVT after a procedure, and also telling a patient of the option of not having any surgical treatment. Conservative management, well, what would happen? Do you need to undergo surgery? So really discussing all of those. There are exceptions to Montgomery, and I've listed them there, where you don't have to tell a patient for those risks. But my advice to clinicians is always that these are very, very narrow exceptions, and they should be used in very limited circumstances. So you may say, well, all well and good, how's this relevant to sport? There aren't very many cases, certainly no reported cases in England where we've got the issue of consent in sport at the moment. However, I want to just take you back to a case involving the San Francisco 49ers in the late 70s in America. So the gentleman on the left is Charlie Kruger. This is a very famous case of Kruger against the 49ers. Charlie Kruger was a defensive linesman for the 49ers. He'd been with them all his career, come through the college system, had always had knee problems and underwent surgery for cruciate ligament repair. But he was also on a regime of steroids throughout his career. Not surprisingly, he had various problems towards the end of his career, retired early. Those problems escalated, and he went to see the club doctors, who said there was nothing more that could really be done. He effectively became crippled. He requested his medical records, and on analysis of those records, it became apparent that the club and its physicians had known all along of the problems he was having and the long-term implications of him being on so many steroids and being put out onto the pitch every weekend with those drugs and with those problems. And his argument was, you didn't warn me of the long-term implications of continuing to play, and you didn't tell me that really maybe it was in my best interest not to play anymore, because otherwise I would end up as a cripple. And if I'd known that information, I might have made a different decision, and I might have made a decision to retire early, and that's what should have been done. And he brought that case, and he was successful. It's a slightly different approach to, there. It was brought on an issue of willful concealment, and the 49ers were found guilty of willful concealment, and the court awarded Charlie Kruger $49 million. I'm not sure if that had anything to do with their name, that it was 49 and 49, but anyway, I think the chief finance officer was glad they weren't called the 99ers. So anyway, but you know, the point is there. America was ahead of us in terms of its approach to consent. It very much had a doctrine of informed consent operating many years before we've brought it in. GMC guidance has asked for developed informed consent for some years, but certainly in the law, it was the case of Montgomery that brought it in. So what are the areas of medical risk? Well, as we've said here, ensuring that the treatment could be negligence itself, but there could be inappropriate information given. There could be inappropriate prescribing or a system failure, such as in the Hamid case, that leads to a player not being followed up, and there could also be a breach of data governance. The general data protection regulations come in next year, even though, despite Brexit, and that could impose huge fines, 20 million euros or 4% of worldwide turnover of organisations' overall annual turnover for breach of data governance. So these are all areas of risk for anyone operating within sport. What can be done? I'm often asked, what about waivers or limited liability partnerships? Yes, waivers can be done. Personally, they're not worth the paper they're written on. Limited liability partnerships, again, that's a tool for limiting your liability. But if you want to manage risk, these are the key things. It has to be in the organisation at whatever level that organisation is. There has to be a culture of looking after the players, of respecting the obligations under Health and Safety Work Act in regards to their health and safety and well-being. Development of guidelines, protocols on consent, prescribing, etc. This all shows the culture of the organisation. This is the identity, and these are often the first things that lawyers on the other side, to me, would ask for. They would want to see, where's the consent policy, where's the audit, where's the risk assessments that were done on these players. So if you don't have this, it's a problem. Ensuring that those guidelines are implemented, communicating with those being treated, as well as other professionals who are treating those players, is essential. And finally, if you remember nothing else from my talk, please do remember thorough, accurate and contemporaneous medical records are what we as the lawyers would always ask for, because without that, it's very, very difficult. And I think this map cartoon summarises that. Please do write it very clearly, because if we can't read it, we don't know what you're saying. Thank you very much.
It's a pleasure to introduce Andy Williams, who has been a colleague of mine now for 1 year, and a fantastic colleague at that. I don't think he needs an introduction in the surgical world. He's an exclusively a knee surgeon, performing over 100 ACL reconstructions a year. He's had over 100 peer-reviewed papers and has one of the world's largest experiences of treating an elite population. So he's going to talk about when to retire.
Now this, of course, is the dream of every athlete. They get to choose when to retire, and after a long, illustrious career, around the age of 35 to 40, depending on the sport, they think it's time to hang up the boots. And that's usually the time when they realise that age is catching up, and as a result, performance is declining. Hopefully they'll be financially sound, and they've got to a point where it's just lost its pleasure. So they choose to retire, but unfortunately, retirement for an athlete has a huge downside. Most of us dream of putting our legs up and enjoying time with the family, etc. But if you've been driven to perform at a high level in sport, and then you have to retire at a relatively young age, you have problems. And I've noticed over the years treating athletes that the drug that they crave is that winning, if you like. And I've been in conversation with many players and managers who said it's the winning really that they miss, and that buzz that Chris Coleman spoke about earlier on. Also, we are, whether you like it or not, defined by our work. I'm Andy Williams, knee surgeon. You are, whoever you are, defined by your work. And to have to give up that at an age that's probably half the age of people who are going to retire naturally or even younger is very difficult. And as Jonathan said, half of them don't even have the choice. They have to give up. And you have an unhappy retirement. And this can be due to an acute career-ending injury, which can be devastating. And after a long period of rehabilitation, the player fails to get back. Now, there are many reasons for giving up with a chronic injury. And one is actually, particularly for the rugby players, that having not been beaten up every day for the best part of a year after an anterior cruciate ligament or bigger injury, they actually rather like that and decide to call it a day. Some players think they may get an insurance payout. Unfortunately, it's rarely simple, and they're often disappointed, particularly for the chronic injuries, because the insurance policies won't cover wear and tear as put in the small print. There's also another group, and it's particularly younger athletes who aren't proven, who may have immense talent, who simply because of one injury miss a critical period of time. I used to think it was natural selection, but it's been pointed out to me that probably the issue is they miss a season and they never catch up. If a club's invested in an established player, they're happy to wait and give them a chance. But these young men and women are cast aside. It's a brutal industry, and they may well have missed out on their education and alternative employment. And the other aspect, of course, rather than an acute, devastating injury, is a chronic injury. Players who carry injuries and pay the price for it live a life of chronic pain. They have immense effort to continue. Just to maintain training and turning up at the weekend will involve daily anti-inflammatories. It'll involve extra physiotherapy. Life gets boring and a drudge. And most of those will eventually decide that enough is enough. As a medical practitioner, all of us in the room sometimes have to suggest politely the concept of prophylactic retirement. In other words, if you carry on, it will not be for your best interests. Now, that's obviously a valid judgment, and it's a decision to be made with a group of people concerned. But there are times when I would advise a young athlete to think again about pursuing a career in professional sport. So for knee surgeons, this is the case. This is a lateral meniscal tear. I trim it up, do a nice job, but that, ladies and gentlemen, is the beginning of the end of that athlete's knee. It's simple maths. Every time you run, you put load through your joint. Most normal human beings put between 1 and 2 million cycles of movement through lower limb joints a year. Athletes are putting many, many, many times as much work through the joint. And the typical pattern of this injury is, although the player gets back, over the years they will have problems and breakdown, multiple arthroscopies, and end up with bone on bone. And so if you have a talented young player, particularly rugby players, because they often have a decent education, why not suggest politely they should consider not going ahead with this plan? Rugby has been in the news a lot recently, in the paper yesterday about injuries. My oldest boy is 24, and he's a tiny kid. I've never, ever worried about him playing. He played at a very decent level. But my 16-year-old, frankly, I'm worried about. The ferocity of the game is extraordinary, and we're now paying the price. So sometimes, if there are other options, you need to do the right thing and suggest that the game is over. So how does it work? If you come to my clinic, how do I retire people? Well, it's rarely an immediate decision. That would be totally inappropriate in most cases. But sometimes I'm presented with a player who's come for a second opinion after a long period of treatment. And when I've assessed the case on the day, it may be obvious they've had all of the treatment they should have had, and nothing is negligent, and nothing more can be done. And I will tell them the truth, that now is the time. Most athletes who have a major injury and a long period out may have setbacks and problems along the way. And I think it dawns on them and their family that really it's just not going to happen. After a major injury, it may be evident to the clinicians that the risk of failing to get back would be high, but of course we don't know that. And that optimism from the beginning that the players will thrive on is diminished. Now there's also an unusual bunch of players, particularly in rugby, who actually have to be told to retire. And I'll give you an example. There's a really lovely guy, one of my favourite patients. So I treated on and off for about 10 years. Age 18, he had a subtotal lateral meniscectomy. It was well before I'd seen him. I met him about 10 years after that. He was in his late 20s with bone-on-bone lateral compartment osteoarthritis. Every time he got bent up in a tackle, that knee that was arthritic and wouldn't want to bend would be wrenched, and he'd have to miss 4 to 6 weeks. End of most seasons, I'd arthroscope the joint, we'd get him back at the beginning of the season, and he'd keep going. And so it went on. This was a guy who played Premiership rugby for years, played for his country, and was a household name. And one day at the end of my clinic, I saw his name appear as a last-minute add-on. No one had told me from the club he was coming to see me. And at this point in his career, he'd been the backup fly half for the team concerned. And he came in, and I wasn't prepped as to why he was there, and I did the usual thing, took a history, and his knee perhaps was a little worse than last time I'd seen him, but I was fishing for why he was there. And as time went on, he kept saying, it's really getting quite tough, really, the young guys at the club, make me look a bit stupid, and they can step and go past me. And then he said, well, of course, that the other fly half, the first choice, has got an injury at the moment, and there's a real chance I'll be playing in the semi-final of the Premiership. And what it turned out was this guy was so brave that he couldn't give up. He couldn't tell anyone he had to give up. But what he had wanted from me was to be told to stop. And what he feared most of all was being at Twickenham and being stepped and looking like a muppet. So I picked up on it, thankfully, and I said, I think what you need to do is retire, and I think you need to retire today. And it was an extraordinary experience. I almost blew it, actually. I was very lucky to have picked it up. But certainly the rugby players need sometimes to be told. This is another rugby player who had an awful situation, again, not treated by me. He came for a second opinion, and he had an ACL reconstruction. He got infected. Unfortunately, there was a delay in the diagnosis, and he had irreparable damage to his knee as a result. I saw him 3 months after that, my first consultation with him, and encouraged him because I felt he was about to turn a corner, and in fact he did. And he got back to play bits of a season of Premiership rugby, and in fact he even played for England. But to watch him play was pitiful. He had a limp when he was running. He couldn't run properly. He could pass well, which I guess that was his job, but it was awful. And so he came down for a second opinion with me, and I told him to retire. And this is an excerpt from an article in The Guardian shortly after that. And he says that it took a lot of soul-searching to decide to retire. So in other words, it's not an immediate thing, but the poor guy worked it out. But when someone like the surgeon tells you should call it a day, you have to take his advice. So that was my role in that situation. And he felt it a very hard decision because of what had been happening to him. All the last season, I was taking painkillers. He said a hell of a lot, every day maximum dose anti-inflammatories. And he was constantly having blood aspirated from his knee. And obviously there's a huge long-term implication of this injury, and he knew it was time to retire. So in summary, the situation is complicated. There's no doubt there are many factors, and I find very hard to deal with the situation myself personally. Jonathan mentioned the doctor's ego, and I think he's right. I do not like losing. And I think my mentality is very similar to athletes, and I have to be very careful that I don't want to keep going simply for my own self-aggrandizement. Getting people back on the pitch is an extraordinarily rewarding thing, but you have to be very careful you do the right thing. And really, for most players, a decision to retire is one that's taken slowly over time, and it's a risk-benefit analysis based on the player's wishes, of course the most important thing, their age, their potential for performance or indeed earning, and their risk of regretting it in the long term due to deterioration, but also the chance of me fixing the problem. So I don't give up easily, but if I know I've got to the end, I need to be honest about that. It's very, very important to understand that for an athlete to not be able to perform is a vicious bereavement. I hurt my hand by being an idiot skiing and couldn't operate for 3 months. It was an extraordinarily bad time in my life. I knew I was going to get better. It was awful. I had to face my wife and tell her I'd been skiing with my mates and ruptured a tendon in my hand. and I wouldn't be working for 3 months, etc., etc. And that was just 3 months. To think at a young age, maybe in the 20s, you'd have to give up on what you wanted to do would be an extremely difficult thing to do. So you must show empathy and care about it. These are my financial disclosures. Thank you very much. Thank you. So I'd love to invite Chris back onto the stage, that's all right, and joined by 2 other players who very kindly agreed, as Chris have, to give their own time for free to come and help us get into the mindset, if you like, of an athlete with a career-threatening, career-ending type scenario. None of the players here, Chris included, were journeymen. They were absolutely solid members of teams at the highest level. Dean Ashton, who I remember watching and being excited about as a fan at West Ham and other clubs, so cruelly removed from the game when he had such massive potential. Managed to get 1 cap for England, but it would have been so many more. And has now moved on to be attached to football through punditry, etc. And Shaun Barker, who was captain at Derby County, really central, essential players cut down in their prime. And we're really, really grateful for their help and their openness in coming to join us today. So if I'd like to bring them up onto the stage, please, all 3 of you. Shaun I've known and grown up with actually for some time. I met him before his big injury, which we'll talk about later on. And Dean I've met briefly, but thankfully for relatively minor things. And his problem was dealt with by one of my colleagues. Chris I've never met prior to today, but obviously was fully aware of the situation. But it may be helpful if we just run through, in a few words, the key injury that has brought us here today. So obviously, Chris, yours was a fractured tibia, I think, wasn't it?
Yeah, I did it in a car accident, fractured tibia and a compound fracture in my tibia. I think 16 fractures in my fibula. Yeah. And ruptured cruciate knee ligaments at the same time.
So massive trauma, and that was what, 15 years ago, something like that?
Yeah, 2001, yeah. 2001, yeah.
And Dean, you had a fracture as well, didn't you, I think?
Yeah, I did. A day before my England debut, the medial malleolus snapped away from my ankle joint just in a tackle in training. And from then on, the problem started from then on.
Now, Shaun, yours was a bit more recent, but you had a really freak accident and there was a collision that would be sort of more normal on a rugby pitch, really, wasn't it?
Yeah, it was March 2012. Ball came in from the left. I went to clear the ball. Foot landed on the floor. Keeper came out, punched it, and I ruptured my ACL, PCL, MCL, LCL, patella tendon, meniscus, and got a chondral defect. That's right.
You did. I forgot it was so many things. I do remember it took about 4 hours, but it was obviously a massive injury. We had a straight talk at the beginning of that, and obviously there's a lot of water under the bridge from that moment on. Mm-hmm. From memory, obviously I may be wrong and you could correct me, but I believe I expressed the seriousness of the injury. We'd met previously with a more minor posterior cruciate ligament injury, which you played on with. Mm-hmm. But I've been here before and we've had success getting players back. Currently there's an England winger with bicruciate lateral reconstruction, performing extremely well, and there are other players. But in football it is tough. But one of the views I have, and I learned a great lesson from Paco Biosca as a doctor at Chelsea, with a boy who had a bicruciate lateral injury. I said, well, of course you know this is career ending, when I was speaking before meeting the player. He said, well, do you know that? I said, no, I don't. He said, well, treat him. And of course, we have to go for it. We're in adversity, and the dream is to get back. But in terms of imparting that information to you, do you think I made it clear enough, or was I too depressing or too positive?
How you came across in that initial stage was probably the most important part of my recovery. I knew it was serious. I could tell with the first specialist I saw before I came to you, because obviously I had my scan the first few days after the injury. And I knew that I'd done my ACL, my PCL and my MCL, and I knew that that was going to be a long, long time. We came straight down to see you, and it was even worse than we first thought.
Yeah.
And your response was really triggered how my recovery was going to go. So you were fairly positive. You let me know that it was going to be very tough and it was a career-ending injury unless the surgery went well, and I recovered well. And I think it was post-op when you came in and said that you'd done everything you could and you was positive. From that moment, I knew that there was every chance of me getting back fit. And I was very lucky as well because I had 2 years left on my contract. Nigel Clough was the manager at Derby, and within 2 weeks he'd offered me a third year. So
it was amazing support.
Yeah.
I mean, it's a huge long haul. We'll come back to that. But Dean, obviously with your ankle, you probably have thought that would be okay and you should get back. But it wasn't as straightforward, was it?
No, it wasn't. No, I think originally I did it in August, and from little bits that I'd been told when I was with England, and then the hospital in Manchester, and then came back to West Ham as well, was that by Christmas generally 3 to 4 months should be a normal time to come back. But as a lot of injuries go, there can be complications, and I just never really seemed to recover from that first injury, and the joint never loosened off whatsoever. Obviously, I'm naturally a big guy, quite a stiff-jointed player anyway, so I did struggle with that. And then once I had to go back in for the second surgery with James Calder, it was almost like that was the first surgery, and then from then on, I could be more positive because I started to see a bigger change in the injury. And
you got back from that, and how long before you ended up having problems?
Well, I was out for 15 months. I got back for the start of the 07-08 season, and I was available for the whole season without any issue, and felt like every sort of week I was getting better and better, and I was really looking forward to then the sort of rest of my career, albeit I knew that I understood what an arthritic joint can be like, and that in later life and later in my career I would probably struggle with that. But it was then only at the next season that I really started to get the bigger problems, which was the bone on bone, and then getting little bits of bone chipped off. And as soon as that started, it was
you were in trouble.
I was in trouble.
Now, Chris, obviously, what I know about fractured tibia, it's a footballing injury, but if it's an open fracture, that's a massive thing. And with all the bits of fragmentation you had of the fracture, obviously I'm not involved in your treatment at all, but from the word go, you knew it was serious? Did you know it was career-threatening initially, or was that something that you learned with time?
That's a long time ago, and I think sometimes when something dramatic happens in your life that's in the negative, you try to forget most of it. I remember waking up and one of the doctors at the time saying, look, there's 50% chance you'll never play again. And I think as a sportsman, that's a challenge, and you normally like a challenge, and I thought, no, I'll definitely play football again. And of course, as the days and the weeks and the months went on, and the extent of the car crash and the injuries, we knew about that. And then a surgeon said to me, look, you could play again, but you're not going to be, you won't be as quick as you once were. And I thought, you really know nothing about football if you ever thought I was quick in the first place. So I thought, that's not a problem. I can cope with that. I think for me in the end, I think that got me in the end. I got back to a stage, but I was at my best. I was an okay player at my best, but I needed to be at my best. After the injuries, I wasn't anywhere near that.
No.
And I think, coupled with the pain every day that you're going through, I knew then it was, that was enough was enough.
At the beginning, I mean, we're obviously all here interested to learn and try and be better at what we do. Do you think the information was given to you in a good way, in a practical way?
Yeah, I have to say, I'm super lucky, really. I was at Fulham again, a great medical team. Physios and doctors, they were absolutely superb.
Yeah, so you had the picture.
I got the best of everything.
Brilliant.
They were very clear with me from the start. This is what you need to do.
Yeah.
Every day was really tough. We had a French manager at the time, Jean Sagano, I absolutely loved him. He had a fitness coach working with us who was absolutely brutal. Luckily for me, I mean, I hated this guy every day. I was with him every day, hated him. But luckily for me, now I can live a normal life because what he put me through, I didn't realize at the time, but hadn't I gone through that with him, I probably wouldn't be leading a normal life. I'd have a limp, or you know. As it now, I can still work out. I can go running. You know, I don't suffer too much pain, and that was because of him. But the medical team at Fulham at the time, the head physio was a guy called Jason Palmer, who now works at Chelsea.
Yeah.
Absolutely fabulous. And I think as a football player, you take things for granted when you fit, and something big happens. And then then you step back and think how lucky you were, or you are, to be involved in the industry. And the people who get you ready every week for the games, the doctors and the physios, the jobs that they do, I think you appreciate it more when you really need them. Yeah. And I'm probably speaking for both, for the three of us. But you need to go through something serious before I think sometimes.
To know it's worth, One of the odd things, obviously, all of you have had, is, which normal patients don't get, is the media scrutiny of things. And just from my observation of seeing athletes, I would imagine it's exhausting with endless need to give information. So Dean, yours sort of went on and on. And how did you deal with that? Was that, I presume it was a negative factor in your life, but...
Yeah, it's very, very difficult because, you know, like it was said earlier about sort of I'm Dean the footballer, and what the fans don't see is when I came back, I wasn't the same player. So I used to jump off my left foot, and now I had to jump off my right foot, which wasn't as good. And my left foot was as good at striking the ball as my right foot was, but I couldn't strike the ball with my left foot. I had to curl every shot. So there's a lot of changes that I had to make, but the fans just see you as the same player that needs to come out and produce, and they don't see all the background work that goes on, and that's what's very difficult. And I think it's then even more important for the medical professionals. I mean, John Green's here, who was my physio. It's even more important that they have to constantly kind of pick you up and say, no, everything you're doing is fine, you look fine, you're fit enough, you're strong enough. You're constantly having to sort of build us up because you've got that negative, negativity from the fans, negativity from managers at times that look at you and say they're not picking you. In my case, I wasn't being picked because the manager said, you don't quite look right, you don't look quite fit. I was fit, I was plenty fit enough, but I was just a different player.
Yeah. And as time went by, did it just dawn on you that it wasn't going to happen, or what made you decide to retire?
It was blatantly obvious. It was blatantly obvious because if you can't get up in the morning and walk to the shop to get a paper and walk back, if you can't do that, you definitely can't be a professional athlete. And I was at the point where I couldn't even do that. So I knew it was, but it's still, like you were saying, you almost still need somebody to tell you that fact. And I was so relieved that I could finish and just end it. But obviously then I had to still go through the ordeal of having a fusion and overcoming that. But
aftermath,
I think that's the most difficult thing, I think, for medical professionals, is that you have to be everything to us. You have to be a friend, you have to be a mum and dad, you have to be a wife, you have to be everything, because well, you do, because we're
very modern.
We're gonna
that's coming from
the
Dean.
ball
It's got nothing to do with Shaun.
Because you're going to have to deal with everything that kind of splurges out of us in terms of emotions and feelings, and I think that's what's very difficult for the medical professionals.
And was there ever one period which was particularly low, or is it just ups and downs all the way?
The biggest low for me is that you put in the hours and hours of painstaking work, whether it be calf raises for hours, or whether it be in the pool, or whatever it may be. You do all that work to get back onto the field, and your teammates see you come out, and they're all delighted, they're all coming up to you and what have you, and you go and do your first run, and you know straight away that
it's not right.
That it's not right, and you're going to have to go in for surgery again, and you know that straight away. That's the hardest thing, is to do all that work to then know you're going to have to go back to the start. Yeah.
Now, someone who's done a lot of hard work is Shaun, who is still a professional footballer. He's back, and it's been a long, long road, and to an extent that I think, I've never experienced a player who's had the tenacity and kept going for as long as he has. It's been a very tough road. When we met, the one big mistake I made was to say it'll be a minimum of 2 years to get back, thinking that 2 years was the time. In fact, what Shaun and then some players since have taught me is that to recover from multi-ligament injury takes a minimum of probably 3 years. And there have been a number of repeat operations along the way and so forth, and various rehab techniques, injections, all this sort of stuff. But presumably you'd echo Dean's view, that commitment to the effort of getting out there every day, the slog. Is that the worst bit of it, do you think?
It was, probably in a strange way, it was my favourite bit.
Really?
Yeah, I had the news, and I knew it was going to be a long period out. I knew it was going to be tough mentally and physically, but I kind of saw it as a challenge. Yeah. And I think every time we saw each other, even though things weren't going as well as we planned and as quick as we planned, I always saw a progression. Yeah, so every time there's progressions and there's a step forward,
you were rewarded, I guess.
Was rewarded, and
it's obviously different to your scenario, Dean, where you break down every time you try, which must rip your heart out.
Yeah, you had the problem I had for the first 3 years was a fusion, so I probably had about 30 aspirations of the knee. I had 4 ops in that time as well. But every time I had an operation, you obviously went in and said, surgically, there's nothing I can do. It's in as good a state as it can be. I actually went to America to work with a rehab specialist coach called Bill Knowles.
Yeah, sure, he's well known. Yeah,
and he's a brilliant guy, proper American. Was on me from the second I got there. I had 2 weeks out in Philadelphia with him, and he tested my strength, my control. He read all your notes, everything about it, and said you'll be fine. By the end of these 2 weeks, I think I'll have you jogging and running. And at that point, I was probably 2.5 years into the injury at that point, and I thought, well, if this guy can get us, running in 2 weeks, I can't wait to get us starting work. And 2 hours later, my knee just blew up. And he took me to a hospital, and I was like a monkey in a cage. Everyone was coming around. He was showing everyone to me. There were surgeons everywhere, doctors everywhere. And I did something called orthokine, which really helped the fusion in my knee, and that kind of was a game changer for me. So it ended up being about 2.5 years before I jogged again. I was 3 years before I was on the pitch.
And at one point you were looking amazing, and then you had another injury.
Yeah, which, I've been very lucky throughout my career until this obviously injury, that I've played lots of games and not really suffered with muscle injuries or any other major injury. And I tore my plantar fascia just as I was coming back in the reserves for Derby. I played 6 games, 3 90 minutes. I came and saw you and said, it's feeling incredible. Everything I do is brilliant. And then I tore my plantar fascia. So I had a year out, unemployed, until Nigel Clough got the job at Burton. Offered to get me treatment, and it was the following year that I signed. So my actual coming back on the first team pitch was about 4.5 years post-injury.
And during that period, I mean, it's extraordinary you kept going. Just interested to know why you bothered. What was it?
Well, it's quite ironic, really, because I can't wait to retire. I really can't. And I never wanted to play football. Never wanted to as a kid. Wasn't interested at all. It kind of got given to me, and my dad just thought it was best that I took this opportunity. I'm very grateful that he could. He convinced me it was the right thing to do. But I've spent my whole career kind of looking forward to the day I retire. And in a weird way, this injury made me kind of appreciate what I had more. Yeah. And I wanted to get on the pitch. And the second I got on the pitch, I would happily have retired at that point. But until I got out on the first team pitch, and I suppose I beat this battle that, both me and you were facing.
Yeah, absolutely.
My journey wouldn't have been complete. And obviously, as soon as I got on the pitch, that was...
You succeeded.
I succeeded. I didn't get to the stage and the standard that I wanted, which was to play 90 minutes again. But I got to that stage, and
And here you are. Chris, you mentioned that, you know, you could play football, but not to a level that would have satisfied you. How important is it for you that you would have, if you got back, you had to be the same player? Do you think you would have accepted a level down, or?
Oh, I would have. I would have accepted the level. I would have accepted any level, but my recovery really ceilinged, and I was just tired of waking up every morning in pain.
Yeah. Did you ever consider the long-term effects? Was that a factor, do you think, or do you live for the now when you're an athlete? Do you
No, when I was that age, you kind of think, before I had a car crash, I thought I was going to be a football player forever. You never think 35 or 38 is going to come. You know, and I was probably 30 at the time, or 29, 30. You think it's going to keep going on, and of course the reality is, of course it comes to an end, like everything. But for me, I was probably different to Shaun, where I never wanted that day to come. I never thought it would come, and then when it's there and it hits you in the face. I remember driving home from training, where, like Dean mentioned earlier, I'd had a target, I'd got to it, and actually when I got onto the pitch, it was the same old story. Too much pain. Couldn't run properly. And it just came to a stage where I thought, you know, enough's enough. You know, I don't think that this medical team who are working with me constantly can't do any more for me. This is it. I'm going to have to make the decision, which I really didn't want to make. No. But then it's almost then as a weight lifted off your shoulders also.
As Dean was saying, I mean, the player I mentioned, the rugby player, I just thank God I didn't just send him out with an injection, which I would have done 6 months before probably. But the relief for him, it was almost, I wouldn't say, it was just almost a joyous experience. I just told the guy to give up. I think he was so grateful.
But that comes when you've actually exhausted every avenue. Quite embarrassed, as I said to Shaun, I thought Shaun had retired because I knew about his injuries. And you kind of think, and in my mind I'm thinking, that's a no, to come back from that. I have to apologise to Shaun for saying to him, because I actually thought that because of the extent of his injuries, it's so tough to come back. To be out that for 4 years, to come back is incredible. Mentally, you have to be a certain type of person. Because it's very tough to keep. And again, it's nice actually. It's therapeutic for me to be listening to Dean saying, the supporters see you, the club sees you, and your teammates see you as this. You're not that anymore. It's physically impossible for you to get to that.
They must just rub it in, really.
And it's very tough, you know, to accept that. But when you do accept it, and you say, hold on a minute, I've exhausted every avenue. There's nothing more that can be done. This is a situation now. It's quite enlightening when you come to that stage.
I had an extraordinary experience. I went to Copenhagen to speak about various injuries and so forth in a conference. And I was the only native English speaker there. And they just said, we're going to do this in English. All of the Danish people at the conference then spoke English, including the footballer they got to talk about injury and life after the injury. And he gave a very emotional account of his problems. He had a cruciate injury, joint surface damage, and after several operations had to give up. And he was talking about the aftermath of retiring, and he said it was a relief, but he says not the first year back. He said because you walk to the club and everyone says, oh God, I wish you were playing, we miss you and all this. He says the second year they start to forget you. And I don't know how you would deal with that. I mean, I'm of an age now, 53, that I've, for the first time in my life, acknowledged I might die one day. Not in a morbid way, just it's going to happen, but also retire. And trying to work out what to do, because for me it would be such a difficult thing to do. What I do is work. And in terms of coping with things, you mentioned the family support. That must be critical, I guess. And it's, have you got any advice you give younger players who are in a situation where they're looking down the barrel of retirement? Because having been through what you've been through, obviously you'd have some good experience to hand on, but is there anything that you would advise somebody to be, either the medics or the player concerned, what to do?
I think for me, I never worried, I think, about how people looked at me. I just missed being a part of something. I'd been a part of something all my life. The thing for me is that while I was playing for Fulham or as a professional player, if I ever scored a goal, which was rare, or if we won a game of football, And that feeling never changed for me since I was probably 8, 9 or 10, playing with my local team. It's just about being part of a team. I knew I was super lucky to be a professional football player. But it was all about being part of something. And when that's ripped away, that was tough. It was tough.
Has your success back in football now, has it replaced that 100%?
Oh, no, I always miss. We were at obviously the tournament last summer and kind of looking at our players standing in the tunnel. Like I said earlier, you can hear the crowd, and I wanted to be right in the middle of that, and it's obviously never going to happen. It's never going to happen again for me, and I'll always miss that. That's just how I'm built. People are different. But I tried coaching after playing, and it was okay, but I never really got that real big buzz and rush until I started managing. That's where I got my excitement. It's the closest thing for me to playing. Other players get it from coaching or going into the media or whatever. It depends on how you're built, I suppose. But
Dean, obviously you're sort of slightly more peripheral to football, but you're obviously involved. Do you get a reward from that? Do you get your fix from that, or is it just not a replacement?
I do, but I think the big thing for me is that I've got a purpose. So what I loved about football was that every single day I had this real purpose about my day to go in, to improve, to get better, or even if it was the rehab, I'd wake up and I've got a purpose. I'm going in there, I'm doing this, and this to get there. It was having that purpose, and I think that's maybe one thing that players don't have when they retire is to have something else that gives you a real purpose that you can try and get better at and enjoy. And actually, the first 2 years were awful mentally, really awful. But then after that, you realise there's so much more that you can enjoy away from football. Drinking, for one. Christmases,
Personally,
holidays,
I've never tried that.
There is so much more you can enjoy that you miss out on when you're in the bubble of football. And if I was to speak to people, that's what I'd try and say, is that there is a lot more than just football.
Well, that's fantastic. And Shaun, you're like some of my rugby players who've just realised that not being beaten up every single day is quite nice. You had a lot of time to think about that, and yet it still kept going. But you fully admitted that retirement isn't such a terrifying thing for you as perhaps some people. But looking forward, do you have plans for that? Because having the purpose, I think, is a key thing, isn't it?
Yeah, I think I'm at Burton Albion at the moment, and my job really is to be available for games for 5-10 minutes at the end of a game. The gaffer sees the importance of sticking a big centre half just in front of the back four with 5 minutes to go when you're under the cosh, and that's kind of my purpose now. It's shifted to what I was used to doing, which was playing 90 minutes on a regular basis. Twice a week, how many times you play in the championship. So my purpose has changed, and I think retirement for me would be easier just because it's been a slow degeneration of my body, of my knee, of my playing time. Everything's kind of slowly gone away from me. I think it would be a lot more difficult that if you're in your prime and you still think you can play and it gets taken away from you. I think I would have found that harder. So I remembered how I felt at 29 when you should be in your prime as a centre half. I was at the biggest club that I've been at. I was club captain, and that was such a feat for me. I was never blessed with ability. I always work hard. 110% every game. Proper old-fashioned centre half, head it and kick it. So to get to that level, to play for a club like Derby County was a huge thing for me, especially when I was living in Nottingham and a Forest fan. So, so it was huge. But it's been a slow, gradual process to when I do retire, whether it's the end of this season. I'm only contracted till Christmas anyway, so it's inevitable in the next 6 months, year, and I'm not scared of that. But I've had a nice kind of time to breathe about it. Transition to the next life, and because I've had a different outlook to most people in football. With people in football, that's all they want. They just want to play. And I still see players every day that can't move, and they'll still go out on a Saturday and perform for 90 minutes. Not interested in training if they don't have to. They just want to get that buzz. And that's the only thing that I really miss. Because I know I'm not going to do it, and I know I won't do it from as soon as football finishes. And every footballer that have retired or that doesn't get to play it on a regular basis miss that buzz of standing in the tunnel. And I think for me, throughout it all, emotionally, I've been fairly level.
Yeah.
So although you have the highs,
amazing.
highs and lows, they're the best things about playing football. I love it when it's been bad and you've got to regroup as a team and as a squad and as a player, but I don't get carried away at the height as well. So for me, it's worked kind of quite easy throughout that.
Let the floor open for any questions. We've got 10 minutes, so there's a hand going up there. We've got some microphones coming round. Susan from Highbury.
So, Susan Alexander, shoulder surgeon from Fortius. Thank you very much for sharing your experiences with us and for being so open about it. I have a question for Dean and Chris. Now that you've gone on to lead very successful careers outside of playing football, looking back, do you think you retired at the correct time? Or if you had your time again, would you make that call to retire earlier?
No, I think I retired at the right time for what my injury was, and if I wanted to lead any sort of a normal life, so go outside, run around with my children, walk with my wife around the shops, which I don't want to do, but if I had to, then I would do. Then the only option really was to retire when I did, and like I said, it was a relief to retire. But having had my ankle fused and how well that has gone, and I've had not 1 minute's pain since I had the fusion, I almost feel like I could play now rather than obviously back then. But I know I can't, so I think it was absolutely the right decision, and I wouldn't have wanted to carry on if I didn't have to.
Yeah, like I said earlier, I think once I'd exhausted every avenue and there was nothing else I could do, nothing else that could be done for me. There was absolutely no chance of me playing football. Then I knew that was definitely the right decision. And I think then you start thinking all the things that Dean have just mentioned, leading a normal life basically. And then you can start looking forward then. I've already said I'll always miss playing, but I know in my heart I couldn't have done anything else to continue playing football, which is all I'd known since I was very young. Once I'd known that was over, and it was definitely the right time for me to say that's it, then I could live with that, I think, for the rest of my life, knowing that there's nothing else that could be done. It was just one of those things. It's done, it's finished. Let's move on, let's move forward. And I actually didn't have the first 6 months or the first year or the second year. It was pretty quickly after I'd made that decision. I don't know why that's the way it was for me. I quickly moved on and just got into something else, and I never forgot about playing. I always miss it. But I had something else to look forward to. I was focused on something else. But I think it was the right time for me to make that decision when I did.
Another question.
Charlie Thomas, third-year student at the University of St Margaret St John. I think we've touched upon, with the Chris speaking first and now this open interview, the stigma that I think gets attached to professional sport, particularly Premier League football, that comes from fans and the media, that professionals are expected to perform, and it's not seen the pressures that they're under with injury, etc. It was talked about on Match of the Day by Alan Shearer that players actually very rarely in his day played with 100% fitness, as Chris spoke about when he played. As the medical skill set that teams can offer, medical teams can offer professional clubs, and this is an open question to the three of you, how do you feel that the pressures applied to sport and the sports your playing careers have changed, and how has that changed the stigma attached to your careers as for Dean and Shaun as players, former and current, and Chris as a player and a manager? So how has the stigma attached to sort of no pain, no gain, the pressure from the media and outside influences, how has that changed as your careers have progressed and are progressing?
So that's probably subject for an entire conference, but if you don't mind, I'm going to summarise that because time is precious. But I guess what you're asking really is about the level of expectancy from the industry, which is an extraordinary thing, and the risk of players not being able to achieve that. I hope I've summarised that well. So Shaun, in your time, how long have you been a professional footballer?
15 years.
15 years. So from start to finish, has the nature of the game changed a lot, would you say?
Massively. I started my career at Rotherham United, which was proper old school club, all experienced players, and if you had an injury, unless the physio ruled you out, you played. And for myself now, if I was fit enough to be playing, I would still leave it in my hands to make that decision whether I played or not. Whereas a lot of players coming through now rely on the physios to step forward and to give the opinion of whether or not they're fit enough to play in that game. And I think it's, in lots of ways, it's such a positive thing that the player now feels less pressure in themselves to be available for them games.
So that's a good thing.
Great thing. But if it was me, I'd still make that decision. I'd tell the physio what the problem is, but if it came down to me, I would say whether or not I'm fit. But that's a player that's comfortable within themselves within a football club. You know, you have young players coming through, and if the manager says that he wants you to play, it's hard to say no. But I think managers now are starting to adapt. They're starting to listen to doctors, to physios. There's more about the place. All the clubs I've been at, there was one physio and that was it. And now I wondered, sports science and doctors and all that stuff. Exactly, and there's so many opinions that can go back to the manager, and then the manager can make that decision for them.
So I was worried with Chris, perhaps you say that the doctors are soft, and it's for you so frustrating, but actually it seems like you've got that team you trust, and you mentioned that a big word.
Trust is huge, I think. But I do agree with Shaun. I remember as a player when I was 17 or 18 playing for Swansea City, and I remember there used to be a very famous striker back in my day who was very tough. His name was Billy Whitehurst. They want to cross this fella. He hit me once. I remember I was clearly concussed, waking up right by the touchline, and the physio was standing over me. In them days, there was a bucket of water and a sponge. I think I had fractured ribs. I was concussed. And the physio said, "Where does it hurt?" And I said, "Everywhere." So he threw the bucket of water all over me. Rubbed the sponge in my face. He said, "You're okay, go on." Nowadays, of course, it's completely different. That wouldn't happen. I'm glad to say it. Like I said earlier, the game's moved on a hell of a lot. But it's because I think we do listen to the medical team more as managers. I think our egos, we've had to park our egos up and say, these guys know what they're talking about. We need to trust them. And I think that's beneficial then for the players.
I think on that note, it's probably a great time to wind up. I'm not sure we answered your question. I'm really sorry if we got it wrong, but that's my fault. But I'm stopping there because partly it's time, but also to think we come on from a bucket of water to what we can do now. I'm thrilled to hear that story. Thank you very, very much indeed to all three speakers.